Hello, everyone, and a very warm welcome to our briefing today. We are delighted to have you all with us as members of the wider AMREF family. It's a real privilege to have you here with us, and we're really grateful for you making the time. So today's webinar is designed to give you a bit of insight into the ongoing Ebola outbreak, which was declared a public health emergency of international concern by the World Health Organization about 6 weeks ago. And today you're going to hear from the people who are best placed to talk about the outbreak and its progress, and also AMREF's response. So that is our colleagues in Kenya, Uganda, and South Sudan. There'll be time at the end to ask questions, so you can either ask them as you go along by putting them in the chat. I'll be keeping an eye on that. Or I can come to you at the end if you'd like to raise your hand and ask directly. So the session will be in English, and I'm very aware that I myself can have quite a strong accent, and I also talk too quickly when I'm nervous. So if at any stage anything isn't clear, please don't hesitate to interrupt. We really appreciate that we're speaking to an international audience. But if English is not your first language, you should have the option of enabling subtitles on your Zoom. And we also are very lucky to have an Italian interpreter here for our Italian colleagues and friends, Massimo. So if you are an Italian speaker, you can connect to the Italian channel. But please let us know if you have any issues. So 6 minutes in, I should introduce myself. My name is Rachel Erskine, and I'm the Global Marketing Communications Manager at AMREF Health Africa, working for our headquarters. And I'm going to pass over to our panel just to very quickly say hello. So Moshin, should I go to you first?
Thanks, Rachel. Hi, everyone. My name is Mushin. I work in AMREF South Sudan, as the head of programs. I lead the programs, all the programs, and the entire portfolio, including the Ebola response. Pleasure to be here, and I'm looking forward to this conversation. Back to you, Rachel.
Thanks, Moshin. Emmanuel, over to Uganda. Emmanuel and Lillian.
Thank you, Rachel, and good evening, colleagues. My name is Emmanuel. I work as a program manager based at AMREF Health Africa in Uganda and currently coordinating the current Ebola outbreak response. Thank you. Glad to be here.
Lillian, you're on mute.
Good afternoon, everyone. My name is Lillian Kamanzi Mugisha, and I head communications and fundraising at the AMREF Health Africa office in Uganda. Happy to be here, and good afternoon.
Thanks, Lillian. And Sarah.
Hello, everyone. Thanks for joining us. My name is Sarah Kosgei. I work also with AMREF in Kenya, and I coordinate climate change and health and also global health security, where we have all our emergency response programs. Pleased to be here, and thanks for joining us.
Thank you, Sarah. So we've got a really broad and deep range of expertise with us today. And finally, to my colleague Sonia to say hello.
Hi, everyone. Really pleased that so many of you could join us today. I'm Sonia. I'm the head of fundraising and development in Rachel's team, also at the HQ of AMREF Health Africa.
Thank you. So we know that Ebola has been in the news in many of the countries in which we live, but it is also been overtaken by other topics, including the World Cup. So this is a really kind of precious moment for all of us to shift the lens back on to what is a very real and ongoing crisis that is threatening the health and well-being of people in multiple countries. And I should have said at the beginning, we are recording the webinar today, and you will all receive a copy of the recording. So, Moshin, let's go to you first. So you're joining us from South Sudan, and South Sudan, as many people will know, is the world's youngest country, turns 15 years old later this week. So as we approach this kind of milestone anniversary, it would be great to have a bit of an insight into the situation in South Sudan. It's probably the most fragile context that AMREF works in, so the dynamics that you and the team are facing can be quite different from our other countries. So could you give us a bit of an insight into the situation in South Sudan at the moment and the different challenges that the health system is facing?
Thanks, Rachel. I mean, yes, in about 2 days we turn 15 years old. So, over the last 15 years, it is important to understand that the entire health ecosystem, more or less, was carried on the backs of the donor support. Um, about about 76% of all health funding comes through donor funding. And the government has only allocated about 1.2% of the national budget this year, which is even lower than last year, which was 2.2. Now, that being said, over the last few years, South Sudan has had funding cuts every year, going from one year to the other. And in the end, what we're left with is very little, very limited. Now, take Ebola, for example. On both sides of the country, we have about 1,400 kilometers of border that is crossing into Uganda as well as DRC. And even when we are trying to respond to this, and we are as AMREF, we're quite lucky in terms of the response because as AMREF, we were credited by both the national ministry and the state ministry as having been the first to respond in that region. And it was by virtue of us being there for over 50 years. In certain places, there is very little of a government that is remaining. There is very little of a ministry of health that is remaining in those regions. And by virtue of being there for so long, undisrupted, and having never left the region, even during the liberation struggle and even when the struggle was going on with the Khartoum regime, we stayed around, and that created such a that cemented our outlook towards us being part of the ministry. And in some cases, if I were to go as far as to say that we are the ministry in some cases, because we are the ones that supplement the ministry, we are the ones who sort of organize and coordinate the activities as a whole in terms of the ministry. So again, South Sudan is very fragmented, very fragile. And as we speak right now, if you look at our hospitals, half the hospitals actually have bullet holes in them, half the hospitals have no roofs. We are running on absolutely no surgical staff. At the moment, there are several hospitals that we run ourselves that have absolutely no surgical equipment at the moment. In fact, one of the regions right now are facing mass casualties because of intercommunal violence that is coming from the Sudanese border. So that all that being said, we are resilient enough to take this effort, and AMREF, I have to admit, is one of the only organizations who have always been there, and we will continue to be there. And we were lucky enough to have support from the U.S. office, from the Netherlands office, in order for us to at least to try and be the first to be there. Now, when it comes to Ebola in particular, at the very start, it's unfortunate for me to tell you this, but a lot of promises were made by many different partners, many different organizations, many different entities. However, very little of that translated to what is actually needed on the ground because of the distance, because of the lack of mobility, because of the lack of the distance, because of how hard it is to get there, because there are several places that you'd have to go through active war zones and active fighting and conflict zones. So in order to actually for us to be there, for other partners to come there, it was far more difficult. By us, in virtue of being there for so long, we were able to take it up as soon as we received the right support. And that is what we were thankful for so long. And that's something that I have to admit, that was something that sort of cemented our place. And everybody understood that we were there. We were the ones who started, and we are the ones who are addressing this in the front line.
Brilliant. Thank you. So Ebola has really come on top of all these other challenges that the country is dealing with. And what is it that AMREF is putting in place? So my understanding is that as of today, there are still no confirmed cases in South Sudan, but it still classifies it as highly high risk. So could you tell us a little bit about what that risk is and how we are mitigating it?
Yes. So at the moment, we have no cases, but given under the circumstances of how South Sudan is placed, especially within the borders, if you look at one of the regions, which is Western Equatoria State, which we have been in that location for over 50 years, that is actually where we have our Maridi Health Science Institute. Um, if you look at that place, a lot of migratory movement happens there, and about 50% of that is because of community reach, community gatherings, because it is a porous border of about 820 kilometers. And One of our biggest fears is that about 18% of the movement that happens between DRC and South Sudan is because they are seeking better health. Now, in as much as I know that our health system is flawed, it is still a little bit better than what is in the other side. And as a result, people from DRC cross over to seek services in our hospital, which is about 24 kilometers away from the border. And in as much as we have set up screening sites, remember there is no gate, there is no wall, there is no border. And in as much as we have the capacity, we lack the capability. Now, take for example, even sample collection and testing. About 3 months ago, we lost, the US government ended up sort of taking back all the equipment that they had given to the lab and taking it back from the lab. So even at a certain point, not so long ago, about 2 weeks ago, the lab still didn't have fuel to run the generators. So all the testing facility had to either be done in Kenya or had to be sent to Uganda. And that meant all these challenges left us with a situation where, in as much as there are no cases at the moment, and I really hope I'm wrong, I do believe that at some point we will wake up one morning and see all of these erupt in one day. Because it's hard for me to understand that with all these things going on and with all the porosity of the borders, it is hard for us to understand that nothing has imported itself. Remember, South Sudan is a landlocked country. We depend on everything from outside, particularly Uganda, particularly DRC, and most of the food sources, most of just about every economic, anything that adds economic value comes in through those borders. And it is impossible for us to understand that nothing has crossed over. It is just that we are doing our level best, but what we are doing is very limited, and we need to do more in order for us to at least try and contain this. And I know that at the moment we are in its containment phase, but I do think that at some point something will cross over very soon. And at that point, we need to shift to make containing it within the country. And that is where we lack the capability, especially when it comes to labs, especially when it comes to our hospital resources, even when it comes to our staff. Remember, the health workers in South Sudan are almost always incentivized by donors. They have not had their government salaries in 14 months. And unfortunately, the World Bank and UNICEF project over the last 6 months had not even paid their incentives. So you're working with staff who have not been paid, with equipment that is at times non-existent, and a lab facility at the national level which doesn't even have a running generator at the moment. So in as much as we have had no cases, I do sincerely think that at some point, if it does reach us and if it does get through, if it has not already, we are in a lot of problems. And this is what I wanted to clarify.
Thank you. That was very clear and very compelling. Thank you, Machine. I'm just showing a map here from the United Nations OCHA coordination mechanism that shows the different NGOs that are taking part in the Ebola response. And you can see here how present AMREF is, especially in the west of the country on the border with the DR Congo. So thank you, Machine. We'll come back to you to talk about how that the response could evolve and what you could do if you did have those extra funds. But for the moment, we're going to go to Uganda. So Sonia, I'll pass to you, Emma and Lillian. Thank you.
Thanks, Rachel. Thanks, Martin. So I'm going to ask Emmanuel and then Lillian a few questions. Coming to you, Emmanuel, I know that in Uganda, AMREF is also focusing on prevention, but can you tell us more broadly what the pillars, what the pillars are of AMREF's response and where you're operating and why you're operating in those regions?
Yes, thank you. Thank you very much, Sonia. As AMREF Health Africa in Uganda, we are currently working closely with the Ministry of Health, and we are supporting mainly 4 different strategic pillars in the current Ebola response. One of the key pillars where AMREF Health Africa in Uganda is participating is in the pillar of coordination and networking. We work closely with the Ministry of Health at the national level, Then at the regional level, we are also working closely with the Public Health Emergency Operation Center. Then at the district level, these administrative units, we work closely with the district task force response teams. But most recently, we've also been collaborating with the task force response teams, cross-border task force response teams, where we have collaborative meetings and activities with the teams in DRC, given that our operation areas are neighboring the Democratic Republic of Congo, as well as with the response teams of Southern Sudan. The operation areas also we share with Southern Sudan. The other area of focus, of course, is in terms of surveillance, where we are currently supporting surveillance activities, particularly along the districts in West Niles. These are mainly along the points of entry or the border districts. In addition to provision of essential infection prevention and control materials, we have also built capacity of a few VHTs to be able to conduct community-based disease surveillance. The other components of risk communication and community engagement, my colleague Lillian will highlight on that. But quickly moving at why we are working where we're currently working. As I mentioned, we are in West Nile region. And as we know that Uganda shares a vast border with the Democratic Republic of Congo and Southern Sudan. The border stretches about 500 miles from Western Uganda to West Nile where we are. And this also connects to the Southern Sudan. And the porous borders or the porous entries are they're in hundreds, where cross-border movements are really difficult to control. So this really puts Uganda, but as well as the Republic, as well as Southern Sudan, where we share the same borders, at high risk of border transmissions. So this is briefly what I can say, why we are working where we currently work at the border points and our contributions on the different response pillars.
Thank you, Emmanuel. That's great. Can you just explain what a VHT is?
So VHT stands for Village Health Teams. So these are volunteers who are selected by members of the community, and they are oriented or trained, basic training by the Ministry of Health and partners on how to conduct health education and health promotion within the communities. So they live within the communities. They are a team of 5, targeting a group of 1,000 people who live in a village according to our Ugandan context. So these are the volunteers who promote and health educate communities about their different health plights, particularly primary health care.
Thank you, Emmanuel. That leads nicely on to what Lillian can talk a bit more about. So, because the VHTs are really important in our response. So, Lillian, what we know from what you've told us is that one of the biggest challenges in prevention and also seeking help at the right time is that the amount of myths and misinformation that there is at among the population at community level around Ebola and its causes. Why is this such a problem, and what is AMREF doing to address it?
So thank you so much, Sonia, and good afternoon, our guests. One thing I would share is that misinformation and myths are very, very dangerous to an emergency response. And this is because it creates fear, it creates stigma, it creates delay for people to seek care, and also it creates situations of denial. So it's very important that this information that is being listened to by many people in the community is interrupted with the use of risk communication information and also community engagement. So why this is very important, it's really to interrupt the the increase of misinformation within the community. Because if they continue doing that, then whatever else you're doing, even if it's giving medication or trying to stop the spread, if people do not believe what you say and they are believing something else, then whatever else you're doing might not really achieve what you would want to see. So why AMREF has taken on the pillar of risk communication and community engagement, it's to really interrupt these myths and misinformation. And what we do is we are supporting the Ministry of Health to actually reach the last unit in a community, which is a home, with our village health teams who have been trained on how to disseminate already approved information by the Ministry of Health and WHO. So this information we are disseminating on Ebola or on any other emergency disease that comes up is usually approved by WHO and Ministry of Health. So with that, we are able to actually translate this information in the different local languages. In Uganda, we have about 53 local languages, but for this case, we've even translated materials in both French, Lingala, Nweri, and Dinka for those communities, the South Sudanese communities, and also the Congo community. And for AMREF, it's even unique with the West Nile region, because in this region, we have refugees from both countries, and these refugees continue getting their relatives, their friends to come and visit. So along the way, our major worry was that there might be a community a transmission of the disease, especially as they keep interacting. The other thing, especially with the mints, is and also our cultural behavior is on the element of burial. If you've been following the news, I think there was a lot of agitation from communities in Congo who also, we also have the same tribe in one of the districts we are supporting, the Zombo district. They have the same behaviors when it comes to burial. They touch the body, they want to prove the person has actually died, they bathe the body, and that's where some of the transmissions happened, especially those that came into the country. Many of them had come from burials. So we try to communicate and provide information on decent and proper burial of these communities. We also try to engage them before the burial teams arrive in a community, so that we are able to calm the community down and to tell them that, this is, we are going to do the burial differently, and it's going to be done by government. So we have also ensured that we distribute Ministry of Health approved information, education and communication materials across the country. And the funds that we've gotten have really been very supportive, because as the emergency begins, so many partners promise to provide. But as we talk today, most of the provision has really come from AMREF when it comes to the information and education communication materials. That's what I can say for now. Thank you.
Thank you so much, Lynn. I think that paints a really, really detailed and vivid picture of what's going on day to day. And handing back to you, Rachel, then, before we go to Sarah.
Thank you. So yeah, Sarah, we'd love to hear from you a little bit briefly about what's happening in Kenya, where we're also in the preparedness phase. But also, given your portfolio of the climate crisis and also public health security, we'd love to sort of zoom out a little bit and hear about what outbreaks like these tell us about the health systems across the continent. So what is happening in Kenya at the moment, and what is AMREF doing as part of that preparedness phase?
Thank you, Rachel. And for Kenya, as you know, we haven't recorded any positive case, but then there's been multiples of alerts and suspected cases, but then the results have come out negative. which is a good thing then because we continue to strengthen surveillance. And so for what we're doing in Kenya, just like South Sudan and maybe Tanzania that have not recorded any case yet, is trying to fortify our health systems. And so working with the National Public Health Institute, who are mandated in leading public health security in the country, we are working with them to do a couple of things. Number one is just first, if there was a case today in Kenya, for example, what would be the first line of response? So issues around surveillance at the point of entries, because if you don't catch it early, then you risk exposing to the larger community. And so all the testing at the points of entries, but also follow up for any suspicious deaths from the community. And this tells us one thing, that at community level, surveillance also needs to happen, because then they can report any death that has occurred that is unexplained. And so the health security team will then find out what was the cause of that death. So surveillance is one of the things that we are doing, and we are supporting the Ministry of Health and National Public Institute to do that. And then also preparing surge. So surge capacity, training of healthcare workers, stockpiling PPEs and also the personal protective equipment, but also ensuring that our labs are ready to continue testing. So that is happening in Kenya. And in Kenya, we only have 4 labs in the whole country that can actually test. And these labs are not centrally located. And so issues are about sample transportation, sample referral for them to be tested is something that we are also supporting. And then issues around risk communication and community engagement. I don't want to belabor what Lillian has said. And it's because also this is happening where the communities are tightly knit. And so we don't want to have a community that is hiding symptoms because then they're afraid that this person will be taken away. And so what we do is through community health promoters and also through local channels, we are educating communities to say, hey, if you see such symptoms, please report to your nearest health facility, and that will be taken care of. And also telling them that this is something that the government is taking seriously and will be able to help to protect everybody else, and respecting the social norms, because for burials, for example, it's very intimate for communities. And so as much as you have to do this safely, you need to explain to them why you're doing it that way. And so risk communication is not something that you wait until the outbreak has happened. You have to continuously educate the communities. And we're doing that through community health promoters. And then the other one is just ensuring that in case there's an outbreak, there's still continuity of services. What we learned from COVID was that after the COVID period, issues around antenatal care, HIV treatment, and non-communicable disease medication, people were lagging behind because they had left that and everyone was focusing on the epidemic that was happening. And so for AMREF, we're still strengthening the primary health care levels to continue offering the primary care services as we move along to actually prepare and be ready for if an outbreak comes. So that's what's happening in Kenya, Rachel.
Thank you, Sarah. Very clear. And I mean, I don't think you're belaboring the point at all, because as you know, it's key to the success of prevention efforts. And it's also something that makes AMREF unique in its response and makes us particularly well placed to intervene, as Mohsin was saying, and as Lillian was saying, to that level of trust that we have, both at grassroots community level and among local and regional authorities. So thinking about health systems more broadly, AMREF does a lot of work at a programmatic level, but also in terms of our kind of advocacy and policy making work to strengthen health systems across the continent in a sustainable way. Can you tell us a bit more about what kind of health systems we are trying to build?
So I think resilience is very critical. And even in our strategy at AMREF is we realize that you cannot stop threats coming. You cannot stop climate change. You cannot stop all this. But how can you ensure that if this happens, if there's an outbreak, the health facility can actually still serve the people that need that, but also bounce back? So for example, if there is an Ebola threat right now, will other services stop or will they continue? So that ensuring that continuity of services, even within threats, is something that is key to us. And this includes just building capacity of healthcare workers who are in the front line, but also making sure that these health facilities have the diagnostic equipment that they require to be able to provide the services, and building their surge capacity to say, in case there's a whole roster of, say, field epidemiologists that are required to be taken to a county X where there's been an outbreak, then you're able to do that. And so some of the health system work that we're doing is just what the epidemics have exposed, that immediately there's an outbreak, there's huge gaps, especially in the whole aspect of human health. And we've seen how many all these outbreaks are usually almost 75% of them are actually of zoonotic origin. Even Ebola now is because of that crisscross between animal and human beings. And so the One Health approach is very critical. And this is also what government does, where for Kenya, for example, where we have a One Health strategy that helps to work towards those multidisciplinary spaces of environment, of animals and human health sectors, to be able to actually build community resilience. And then they need to institutionalize the same, because then if it's not institutionalized, then it becomes siloed and then it becomes one-off. And so institutionalization of One Health approach is very critical through the One Health strategic plan. And also for the region, I think Africa CDC has been leading this, especially around One Health approach, but also building lab capacities across the region. And then the community engagement piece, that one is really something that needs to happen forever, because then that is where health is, that is where communities feel the impact, and that is where interventions are required at the last mile. And then so that drives us to the need for community-based surveillance and community-based education to ensure that you are able to demonstrate that the health system need to be able to actually respond, but also continue providing services for the communities as long as it's required. And right now, we all know that the Ebola virus, the Budebiro virus, has no vaccine yet. I know there's been trials that are going on. And so our biggest defense right now is prevention, and community engagement becomes like our vaccine of the day, because then that's how you prevent this from spreading within the communities. And so there's really a lot around just prevention and early seeking behaviors, but also strengthening that infrastructure to be able to deliver for communities.
That's brilliant. Thank you, Sarah. Thank you so much. And if we have time during the questions, maybe we can hear a little bit more about community engagement, because I know it goes two ways. We also are drawing on local knowledge and Indigenous knowledge to build those health systems. So back to you, Sonia, I think, for a couple more questions to our panelists.
Thank you, Rachel. Yes, I just have one main question to each of the panel, and then we'll have some time for questions from the audience. And the question really is, well, it's sort of several questions all in one, but why is it so important that AMREF is able to continue the work that we're doing, and to ensure the continuation of our Ebola response? And based on that, what do we need extra resources for? What would we do with them? And why is it so critical? Let's go in order. Let's go to Moshin first, if that's okay.
Thanks, Sonia. So it's very important to understand that South Sudan system, the health system in and of itself at the moment in South Sudan, is extremely fragile. And with that kind of state, we cannot afford to have an outbreak in the country. It will be devastating. There are no drugs, hospitals do not function. We do not even have power as we speak in the lab. And that is where, if you add another element to this in an already broken system, this will be more or less the end of what we can imagine in terms of. So that's why, as Sarah had said, the most important thing that we need to do is to strengthen our existing system. And now you might ask, how do you strengthen a system that is already so fragile? And I need to tell you that we know where that is where the funding is needed the most. We know what is exactly needed in the lab, we know exactly what is needed in the facility, and we know exactly what and how to move the Boma health workers, our last and front line of primary health care. These
Can
are
you
the
tell us,
community health workers.
Machine? Sorry, what's a BOMA health worker?
It's the community health worker at the last front line. It's the front line of primary healthcare. It's the first defense in primary healthcare, and they are the community they're the community health workers that are part of the community, and we know how and where to place them, how to move them around. I'll give you a very good example. I mean, quite recently, a different large-scale entity, a government entity, had given us, or given the ministry, several Land Cruisers. Now, in as much as we appreciate that help towards the ministry, that added more pressure on us, and particularly AMREF, because not only did I have to now look for fuel for a generator to run the RAB, I was also now being pressured to get fuel to run those vehicles. Now, I understand that getting the donations at the right time, at the right moment is very important, and we appreciate every little bit of help that is given to us. But when it is given in a manner with which it is not directed, or is given in a manner where there is little to no understanding of what is actually happening on the ground, it makes things even more difficult. And as Lillian said, there were many promises made at the start, but a lot of it didn't materialize. And where we are as AMREF, we are in such a position because we've been there for so long, and we know exactly where the gaps are from the community, from the facility, from the state ministry, from the national ministry. And one of our key things at the moment is to try and use that system to strengthen the existing health system at the state level and at national level. State level at the hospitals, strengthen our hospital surveillance teams, as well as in national, strengthen the lab. Because without those two, and at any point, if we are to have an outbreak, we simply cannot afford that in a system that we have right now. It will just simply devastate us all.
Thank you, Moshin. And obviously, the point is that to continue the work that we're doing, this is on top of the Ebola response, is on top of everything else we were doing. So the funds, we're looking for additional funds to be able to continue this.
On top of roofs, on top of blown up roofs, and setting up walls that are blown up by bullets, now we have Ebola.
Exactly. And perhaps Emmanuel, you can answer for Uganda the same question, which is why do we need more funds, and what would we do with them?
Yes, thank you very much. As I think cross-cutting in most of the East African, but as well as the African countries, as we've noticed and realized over the years, that the budgetary allocations, particularly for managing health services, have remained low, including in Uganda. From the declarations, including the Abuja declarations, where many of the African countries had been had agreed to increase, for example, the health budget to about 15%. For Uganda currently, the allocation is still way below 15%, between 8 and 10%. So that therefore means that for us to have resilient and sustainable health systems, participations and contributions from partners remain key. AMREF as an organization has been working for over 30 years here in Uganda and working closely with the Ministry of Health to fill the existing gaps due to inadequate funds currently available for running the health systems in general. But in the event of any additional funding or call for funds, we would focus mainly on community health workers. These are the village health teams we are talking about, because these form our first line of defense. And given the vast nature of the border we currently have, but also the desire for the community health worker, or what we are calling the village health teams, to be engaging in continuous the community-based disease surveillance, so that we're able to detect at the earliest opportunity, not only the current Ebola outbreak, but any other outbreaks of public health or international health concern. So would gear that would channel those funds towards ensuring that the community health workers that we currently work with, they are able to carry out.
Oh, I think we've lost Emmanuel. Maybe we'll get him back at some point. Let's go to you, Sarah, if that's okay. Just to speak from AMREF general perspective about the need for extra resources to manage the Ebola response effectively.
Yeah, so already WHO has provided guidance on key things that needs to happen for Ebola response, but also for preparedness. And some of it, of course, we've mentioned here, starting with surge response, surge capacity to respond to the outbreak itself, infection prevention, and this includes water, sanitation, hygiene, because we realize that one of the key things is also water because of hygiene and spread of the disease. Protective equipment for our frontline healthcare workers, but also for communities who've been exposed. Issues around surveillance, and I think we mentioned a little bit about the strengthening lab capacity. And this is not only for the point of entry, but also at community level and also for contact tracing. Because remember, someone may be in contact with an exposed patient of Ebola, and so they go on their way. And so if we are not able to track those contacts, and I think this we've seen in DRC that contact tracing has really been a challenge, and that is where the core is, because by the time you get them, they've spread furthermore. And so contact tracing is really critical, and so surveillance is one of those critical things that we would use the resources for. And so lab capacity is very critical. And then issues around just strengthening community engagement and coordination. I think we've seen what is happening within countries, not only because of Ebola, but also any other disease that is not unexplained. It is important to continuously engage communities to protect our families and our homes. And I think we're also reminded that health is not just the absence of disease. So sometimes you will think because you have 0 cases and you're celebrating to say, hey, we're good. But no, the system issues need to be checked. So for Kenya, for example, we did a risk assessment and we realized that Kenya is still under 70% preparedness. So that if Ebola, for example, was to strike today, we're not prepared to actually support that because we have gaps in surge capacity, we have gaps in isolation centers, and where there's an isolation center, is just a shell to say, hey, this is the space. But it doesn't have all the equipment and tools that you require to be able to actually effectively take care of the patients that are in there. And so these resources would be very useful to help doing those 7 critical things as guided by WHO, but also for countries like DRC, where AMREF, we don't have physical presence. AMREF, we really use our footprint because we've worked in countries where we don't have physical presence. And because then for us to create an office in a country, there's a whole modality to do that. But where we don't have physical presence like DRC and Rwanda, we have partners already on the ground because we believe in local leadership. We believe in organizations that are actually in touch with the ground. And so for such, we already have a list of partners, potential partners to work with in DRC, and we've engaged with them before during COVID, and they're doing great work at community level. And so such are the modalities that we will be using to really work in areas where we don't have physical presence ourselves.
Thank you, Sarah. Okay, we've got some time at the end for questions from the audience. We've had 2 questions already, but I would invite anyone else, any of our participants who has a question to put the question in the chat, and we can ask the panelists or relevant panelists, and I think that works for Italian and English for our Italian participants. But let's start with the 2 questions that we have already. And the first one I'm going to ask you, Sarah, is how do how does AMREF evaluate national government's contribution to the Ebola response, financially and in terms of coordination?
Yeah, that is one thing. I think sometimes we work with government and then forget to evaluate because we're saying we're building the systems. But yeah, in the past, I think one of the key things that we do is looking at two aspects. One is sustainability of interventions, and then the other one is ownership. Because as Moshin said, for fragile states like South Sudan, things are a bit different. But then for more stable states like Kenya, Tanzania, Uganda, then also things has to be different. And so for such countries where we have a bit of stability, then we're looking at how is the government organizing itself in terms of bringing partners together. For Kenya, for example, we have like almost 10 partners who are keen on supporting health security. And so what the government does through the National Public Health Institute is to really form a coordination mechanism so that we avoid duplicating resources and also using the resources where it's required. And so bringing all partners together, playing that coordination role and saying who is doing what where, so that we are able to stretch the resources across where it's needed and avoid duplication. And then the other one is how they are providing a policy environment to be able to actually deliver our work. And so the One Health strategy, for example, the preparedness, the country emergency preparedness plans, that is done by government. And also this drives investment. And so for countries, we are seeing where what is the partner doing and what is the government doing. So issues around co-investment is also one of the key things that we look at. And this differs country to country, really, because of the allocation in the health sector. For Kenya, I know allocation for health sector is, for example, 4%. And then that 4%, what happens then? Is it allocated also for emergency response? What we've seen, because it is a devolved government, you'll find those countries which are high risk are already putting aside ring fencing some amount. It may not be the same for every county, but then they are putting allocations to be able to be used for emergency response. And the other key thing is that AMREF, we don't have frontline healthcare workers, as it were. So we use the Ministry of Health nurses, Ministry of Health doctors. So providing the personnel to be able to implement this is one of the core things that we also look at, because then they also need to provide some of the resources within their mandate. And lastly is the infrastructure piece and also surveillance tool. So you will find that different countries would have, say, different surveillance systems. And so this is managed and is hosted by government. So for example, if you came to Nairobi today, there is a system that you have to fill in your travel, where you've come from. Do you have any signs, symptoms? That is managed by the government. And we use that to be able to help in raising alerts, but also in making decisions into what needs to happen within what point of entry. And then lastly is the infrastructure, the isolation centers, for example, and making sure that they are providing health personnel for those isolation centers is something else that we also look at. So at the end of the day, we know AMREF, we're here for a season, and so sustainability really rests within the government. And so key to us is usually, even when we are co-creating programs, we are looking at those sustainability principles to say, hey, this is what we are able to provide with the resources that we have, but what then is government going to do to be able to sustain that beyond the project period.
Thank you, Sarah. That's fantastic. And the other question that an audience member had was about how we're receiving direct news about the situation in the DRC in terms of number of cases, number of treated cases or spread, etc. So perhaps we can hear from Lillian on behalf of Uganda, and then Moshin about South Sudan.
Thank you so much, Sonia. So for Uganda, the way we get to hear about what's happening in Congo in regards to this emergency situation is, first of all, through the networks that we have. and the health port. On every border that is high volume, there is a mini hospital. It's called the Health Port Center. So with those, that's where we get information that we can rely on, because they work together with the health port across the borders under those high volume borders, and those are the ones where we are working. Currently, there are 6, and we are working in those 6 health high volume borders. Between Congo and Uganda. Then, of course, we also get news from our Ministry of Health, because currently they are providing technical support to Congo, and also from WHO and Africa CDC, who are actually in country, and they are providing support and technical guidance to both countries. They are also reliant a lot on the technical expertise for Uganda, having gone through Ebola. I think this is going to be our 12th time, and I think for Congo it's their 17th time. So with that, we are able to exchange information, and because we are sitting on the technical working groups of the response, for example, we have a team that sits on the coordination technical working group for government. We also have one for surveillance. We have one for coordination. We have one for risk communication and community engagement. So on those pillars, we also have development partners like UNICEF, WHO, Africa CDC, actually chairing most of these meetings. So we are able to get updated information, and which is also reliable, that we are able to use. Of course, there are the rumors that are also another form of information that we get, especially from the communities. And these rumors are majorly on who they think has just crossed in from Congo, and where this person is, and where the people they've connected. So we are able to do contact tracing through the rumor channel. It's not the best, but it seems to be working for the communities. So for the national level, we rely on our government, Africa CDC, WHO, and other implementing partners who we are with at the border points. At district level, we have all this information coming through the district health officer, who is the lead person of health at every district. So we sit at the district task force, and my colleague Emma right now is actually on the ground. That's where he's able to gauge where AMREF's contribution is critical. Yeah, that's what I could share for now. Thank you.
Thank you, Lillian. And lastly, going to you, Mushin, about how you assess the level of risk and find out up-to-date information from DRC.
Yeah, I'll start off with the first question as well, briefly, in terms of the government buy-in, in terms of the government support that we have. Yes, we have the coordination mechanism going in from the national ministry, but very little sort of funding or very little sort of monetary support has been allocated to this initiative. It is more about the ministry and the government putting all the partners together to getting them to pledge and support in certain components. That is what that is the more or less, I wouldn't say the only contribution from the national ministry, but that is one of the biggest contributions that we have so far. That the ability to coordinate and get all the partners together and sort of, in order to make sure that there is no duplication. In terms of DRC and getting the numbers, we have WHO on the ground. Again, in that particular location where we work, where we are bordering Western Equatoria, the state ministry has had multiple changes, because of really different political views between that region. The state ministry is more or less not in its place as it used to be. So WHO and AMREF is at the moment coordinating at the border near the Turi region in order for us to understand and as Lillian said, it's all about understanding the communities. We use the community health workers in order to understand who has crossed over, who has not crossed over, because again, it's the same community that is divided by an imaginary border. WHO does provide us as well as the other partners with the kind of incident data in that region, and that is then given to AMREF, and AMREF passes it on to the national ministry and the other partners. So our system is again with WHO, our system is again with UNICEF, and AMREF sort of coordinates that and then passes it on to the national ministry. We do have other partners from DRC who are informing the WHO at the border point.
Okay, thank you very much. We've just got one question and 1 minute left. So Sarah, this is just a question for you, just to see if you know the general trend of this Ebola epidemic. So somebody is asking around numbers and data, but we've where the main local outbreaks are, and then what the general trend is. But we've got like no time left, so just very quickly, what the general trend is, I think, would be the most useful thing.
Yeah, so in DRC, as at day before yesterday, we had already over 1,000. It was 1,307, 1,307 confirmed cases and 377 deaths. That's in DRC, and that is giving a fatality rate of about 28%. And therefore, Uganda, we have 20 confirmed cases, 2 deaths, and 1 probable, which I guess waiting for results. And in Uganda, we've had 3 deaths so far, and that's about 14%. And then in France, there was 1 confirmed case, and we haven't had the outcome of that, if it's recovered or not, but that was 1 confirmed case. But then we will share a link, maybe, I don't know if we have a number, an email to all the participants. We can share a link to the WHO website or the CDC website where people can be tracking those cases.
Thank you. Rachel, do you want to wrap up for us?
Sure. Yeah, I think I've just pasted that in the chat, Sarah. I hope it's the right link. You can correct me if not. So just to say thank you. I'm just going to share some Lillian shared these lovely some images from our response in Uganda, just so that you can get a feel for what things are like on the ground and the shape our response is taking. I hope that this hour we spent together has kind of brought it to life for you all. Thank you again for being here and for all the support you've given us to date. I think our colleagues have made a really strong case for the impact that support has had in terms of enabling us to respond really quickly as soon as the threat became apparent. But also everything else that we could be doing if we had more resources. So thank you for your ongoing support, for being members of the AMREF family, for making the time to join us today. We hope you've enjoyed the time and found it illuminating. And thank you to Marcin, Lillian, Emma and Sarah also, who, as you can tell, they're a little bit busy, but they have also made the time to be with us today. And I guess I've been making notes as we went along, and there have been some really great ideas and kind of sound bites that have come out of it. But I think, Sarah, you said our biggest weapon is prevention. And at the moment, in the absence of another vaccine, it's communities that are the vaccine. And I think that came across very clearly in what all of you said. And that idea is really at the heart of our response across the continent. So thank you. Please do get in touch with any questions, and we will follow up in the next day or two with a recording. I think that's everything. Yeah, Sonia? Yeah. So thank you, everyone. Take care.
Thank you, everyone.
Thank
Bye-bye.
you. Bye.
Thank you. Bye. Thank you, Eric. Massimo, were you okay? That must have been exhausting.